right, well, it is now officially 12:10 when we're due to start, not 12 o'clock. I still am Jonathon Leipsic, and we still have Class 2A support for the use of physiology in clinical practice. We have a really exciting 40 minutes. We want to make sure we have time for conversation. You're going to see a number of excellent speakers, and it's going to be kicked off by Professor Leslee Shaw, who really needs no introduction. She just ran from another room where she gave an exceptional talk on stable ischemic heart disease trials. Leslee will share her thoughts on CCTA with and without FFRCT, the ultimate diagnostic tool. Leslee, please.
Thank you. Sorry, it feels like, the nice thing about these small trials is I get to visit with everybody. The bad thing about these small trials is you're late for everything. Exciting times I'm going to really cover kind of the thoughts that went on with the recent chest pain guidelines. So that's really kind of what I was going to highlight. So I'm going to talk about the comparative randomized trials, which we all know, but I just want to highlight to you mostly from the perspective of what the guideline committee thought. Talk about the guidelines and then the role of FFRCT. So here are the approaches that were taken in the recent ACCIAHA chest pain guideline, which had not been updated since 2012, so 9 years later. Integration of 11 randomized trials in the acute setting, in the emergency department evaluation of chest pain, and as well as 9 randomized trials of CTA versus stress testing or invasive coronary angiography. So here we are in terms of understanding what's going on in terms of stress testing and suspected coronary disease. I mean, there really should be an outcry. This is really abysmal in terms of our diagnostic evaluation. We really have a very low rate of ischemia. During my career, usually when I started off, about 30–40% of patients would manifest ischemia on a stress test. Now that's down to about 5, 6, 7%. So the vast majority of patients don't have ischemia. And in terms of a diagnostic population, as you can see in the middle, only about 12% of patients have obstructive coronary disease. And when we send people from stress testing to an invasive coronary angiogram, the vast majority do not have obstructive coronary disease. This is a hugely inefficient system, which is being perpetuated every day. And it it called so drastically, and it would just hit you across the face that we clearly need an alternative approach. So what about CT? So for years we were saying this is a better test. And so now we were able, both Dr. Ron Blankstein and myself, Renee Bullock-Palmer, were on the guideline committee. I chaired the imaging section of that. And so what we were talking about is CT has a very high diagnostic accuracy. A normal coronary CT, no stenosis or plaque, is the lowest risk group that we could find in terms of evaluation patients with suspected coronary disease. And we can do a heck of a lot better job of selecting patients to go to invasive coronary angiography. That's the understatement of the world. And we can also detect atherosclerosis and better target those folks that need preventive care. These are like no-brainers in terms of the value of CT. So look at, there are 9 randomized trials which are synthesized. If I add on the discharge trial, that's now 10 trials. If there are 2 types of trials, in case you haven't been reading the literature, one is the use in an elective population, a patient that qualifies for elective coronary angiography. In that patient, does CT do a better job than it would be of sending that patient to invasive coronary angiography? There are several trials, and there are 3 trials in that category. Discharge is just one of them. In all 3 trials, there's no difference in outcome. The big difference is that it does a better job of reducing procedural complications, which is really, it's not a major thing. Even in the invasive lab, it's not a high rate of complications, but certainly there's a significant cost benefit from doing CT versus invasive coronary angiography. I think the trials that get the most attention are those that compared CT to standard stress testing. And again, no difference in near-term effectiveness. However, in planned secondary analysis, there's improvements in long-term outcome, and we'll talk about some selectiveness on that with Scott Hart in terms of 5-year outcomes, as well as in PROMISE in higher risk patients, particularly those who are diabetic. CT showed a significant benefit in terms of outcome. Here you see kind of the overall take-home messages from discharge in Scott Hart. So here is the overall evaluation algorithm. Now, many people think these are complicated, but they really have just a couple of approaches for this. And the first approach is, do you take an anatomic versus a stress testing approach? And if you do, either which way you go, depending on the patient population, and then you look at employing FFR-CT potentially in that patient who has an intermediate stenosis, or you could employ stress testing if you'd like, and then invasive angiography is your next decision. Now, on the FFR-CT, the data that was quite compelling to the guideline group had to do potentially with data from ADVANCE showing risk stratification. I mean, that's the classic argument that FFR-CT is a useful measure, but it doesn't really risk stratify. And I think this paper published in JACC Imaging about a year ago showed an elevated hazard for major cardiovascular death or myocardial infarction by about 4-fold, was important. FFR-CT was important in terms of risk stratification. There are other types of ways of looking at FFR-CT. Bong Kwang-Ku likes to look at the translesional change in FFR-CT. Some people have advocated for looking across the vessel, perhaps to pick up more diffuse changes, but it's important, I think, that the evidence is there that this can prognosticate. And of course, I think that this is my second to last slide, but I think it's important to say that many strengths, and this is really what it came down to. To be honest with you, I thought that FFR-CT should have achieved a Class 1 indication. I'm going to just tell you that. I know that seems heretical, but I think it deserves more of a Class 1 indication than the use of, I know Mike Salerno's going to kill me, in the use of MR in the emergency department, because I don't think anybody uses MR in the emergency department. So what are the strengths? What did people like in the guideline committee? High negative predictive value. Nobody can complain about that. Excludes ischemia, which is really important in terms of clinical management. Although we used to hear this all the time, that you had to send the data out, and I don't like that. Actually, most of particularly non-cardiologists, loved that because they could send it out, and it was a near-term decision, particularly in stable patients, and they didn't have to send the patient to another test. They didn't have to send the patient to a stress test. That was surprising to me of the real importance that was placed on that. It's kind of this one stop. I hate to use that because MR used that for a long time, and we know what happened there. Oh, I didn't say that, Mike. I'm sorry. But in terms of consideration, right, patient time, efficiency of diagnosis, and the fact that you don't need additional testing, with FFRCT is just a really important consideration. And, I think the other criticism has been that we don't have randomized trials, but I think we're soon to see the PRECISE trial, which, you have a randomization to a usual care evaluation versus a PRECISE evaluation, which is guided by a PROMISE risk strata in terms of looking at medical management versus the use of CT plus or minus FFR in terms of outcomes. This is going to be an exciting outcome-based trial. No, it's going to have lots of different outcomes, including secondary endpoints, which I increasingly like to see in terms of quality of life, angina, et cetera, in our patients. So I think this is, that was my last slide. This is my last slide. So here you could take a ischemia-based approach. I do think CTA results in a much better and more efficient strategy to invasive angiography. So on that note, I think I'll leave this for my last slide. Thank you.
Thank you so much. Yeah, please. Thank you so much for an elegant talk, and we'll move on to our next speaker. And Dr. Salerno, please hold no grudges. Dr. Shaw just simply speaks the truth. Dr. Pursnani, welcome him to the podium. An excellent clinician, cardiologist, and non-invasive imager, CCTA and North Shore University Health System, the past, present, and future in the era of the new chest pain guidelines.
Thank you so much for that introduction, and thank you to the group for allowing me to speak at this symposium. So, you know, as Dr. Shah just presented this incredible tool, my job is to kind of work with this presentation and talk a little bit about how we implemented coronary CTA within an institution like ours and the trajectory that we've had over the last few years and how we plan to implement this so that we can meet up with the increased demand for coronary CTA in the future in this post-chest pain guideline era. So I work at North Shore University Health System. This is a suburban set of hospitals that are located in the northern suburbs of Chicago. And just like many other health systems across the country, we've had a variety of integrations and mergers with other hospitals. And we started off at 4 just a few years ago, and now we're up to 9 hospitals. We have a hub hospital, which is Evanston Hospital, kind of located in Evanston, Illinois, and that's really kind of where our first CT scanner is. We are academic from the standpoint that we have an internal medicine residency program, a general cardiology fellowship program, as well as now an advanced cardiac imaging program. Our coronary CTA volume over the course of the last several years probably mimics what many of you have seen in your health centers, a big sort of upward rise in terms of volume, and this has really been essentially sort of exponential over the last several years. Our early years, 2016, 17, you see, you know, about 100, 200 coronary CTAs. In 2022, we're projected to have 1,600 coronary CTAs, and based upon our projections for the next couple of years and this increased need with respect to kind of the new guidelines, we expect this number to be in the 3,000 to 4,000 ballpark, and probably several thousand within a few years. So let me tell you a little bit about our early days of coronary CTA. The scene when I first started there back in 2015 was we were 45 cardiologists spread across 4 hospitals and multiple outpatient practices. Lots of primary care physicians, close to 1,000 within our original cohort of 4 hospitals. We only had one cardiac-capable scanner that we felt comfortable doing cardiac CTs on, and that was based at Evanston Hospital. We had adequate CT reading and reporting software. And the one important thing to mention here is there's exceptional support and collaboration between cardiology and radiology. Even though there wasn't truly sort of a spearheading individual on the radiology side, we had a significant amount of support to build this cardiac CT program and kind of take it to the next level. Really, initially, it was really about establishing an advanced imaging presence, always being available, being at conferences, working kind of with trainees, educating them about the powers of coronary CTA. And communication was always key, so that if a coronary CTA was done, being able to kind of discuss that with the referring physician and help them with how to manage the patient downstream. Our focus was predominantly on quality in the early years. We knew our capabilities with respect to our cardiac CT scanner. We selected our patients relatively wisely. We followed the best practices, as you all know, in the SCCT guidelines. Initially, nursing was scanned, but we shared our resources with interventional radiology, and ultimately were able to convince the administration at our hospital, as our volume grew, to have dedicated nurses for cardiac CT and cardiac MRI. We did have early obstacles. Some of those early obstacles, as I mentioned, were limited nursing, limited slots and scanner time. But as we began to grow as a program, we were able to get more slots and more scanner time to be able to meet sort of those needs. And our goal was always, if a patient was to be ordered a coronary CTA, we didn't want to have them scheduled more than 2 weeks out. So that kind of helped us to continue to sort of grow the number of slots we had. One issue back then was that it was mostly a second-line test. So coronary CTA was being utilized at that time at our institution, mostly following a stress test that showed mild symptoms or mild ischemia or artifact or something kind of along those lines. We still had issues with pre-certification and prior authorization. We'd have cancellations that would happen sort of the day, that the patient was supposed to show up for the scan. But as we began to understand these nuances, we had teams of people working in pre-certification, and this became a little bit easier to do. We had some initial difficulties establishing an emergency department coronary CTA program for acute chest pain evaluation. I did my training at Mass General, where a lot of the folks are pretty familiar here kind of with the ROMICAT trials and was very involved with a number of sort of analyses from that trial. And I was gung-ho, sort of pumped when I first started an emergency department CTA program at our institution. But one of the things that I quickly realized is we only had this CT scanner at one of the 4 hospitals. And the way emergency department physicians work is they like algorithms, and they like algorithms that they can follow that are going to be the same at each hospital. So this became a little bit of a challenge for us because the idea of transferring a patient from one emergency department to another hospital to get a coronary CTA was challenging. This was also the era where people were looking a little bit more closely at heart score. High sensitivity troponin had come out, so the nuances of which patients, are truly sort of the best candidates for this. We had some challenges in terms of organizing that, but I'll circle back to that later, and you'll see kind of what we did. Over this period of time, there was an expanding evidence base that you've already heard about and are very familiar with, including outcomes data from PROMISE as well as Scott Hart to show that there were improved outcomes with a diagnostic strategy of coronary CTA over standard of care testing, and also the platform trial which showed increased efficiency with respect to using CT-FFR in terms of more patients arriving in the Cath-lab who truly have obstructive coronary artery disease that are going to undergo an intervention. And I think these studies, these trials, and kind of the efforts that we made at our institution with disseminating this evidence to the rest of the group of cardiologists and primary care physicians started to gain a lot of momentum. And then our focus in 1920 was really that on efficiency, working on pre-medication protocols, streamlining scanning protocols, working on epic order sets. We established a formal relationship where radiologists would read the CT incidental findings on the coronary CTAs. We had shared nurses for cardiac CT and cardiac MRI, and by this time we had up to 3 cardiac nurses that were dedicated for those 2 technologies. We had an increase in staffing in terms of technologists. Initially, we started off with 1 or 2 technologists. By 2020, we've had 10 technologists that were comfortable with doing coronary CTAs. I think of particular significance was the partnership that we had with HeartFlow for establishing the pathway of CCTA, CT-FFR at our institution during this time. We had been working towards that for actually several months to a year before it ultimately took effect. But the higher specificity, the greater accuracy, and the reduction in layered testing was really, I think, a game changer for many of the cardiologists in our group. And we started to see a greater transition for this to be a first-line testing modality for patients with chest pain as opposed to a second line. It also created the impetus for even more communication with radiology management, HIT, security folks, the pre-cert prior authorization. So getting everybody together in one place to discuss kind of how to implement a new technology like this was key, and we kept those relationships going even after we had that technology here. There's also the time, obviously, where the pandemic started, and this actually to some degree kind of helped build a case for coronary CTA/CT-FFR because it was more hands-off versus stress testing, a little bit friendlier for those in terms of reducing risk of infection and so on. And then we also got remote reading stations for what that's worth. 2021 onwards, so this is a new era post-ACCIAHA guidelines, and I think the demand that we're going to see for coronary CTA is going to really be, very much sort of quite sort of big in the future. I think the communication lines that we've built between administration, radiology, cardiology, management, hospital leadership has been fantastic. And now we're focused on strategic meetings, how to sort of meet this volume. And as part of this, we realized that the bulk of our coronary CTAs that were being done were outpatient coronary CTAs. Probably about 80-90% were in the outpatient scene, but the patients would come into the hospital to get their coronary CTA done. So we've made a case to actually develop an ambulatory cardiac imaging center, and it's going to function as one of sort of 2 things. One is an ambulatory chest pain imaging center where we see chest pain patients with recent sort of onset chest pain or urgent chest pain that are not quite sick enough to make it to the emergency department or to avoid an emergency department visit, where those patients can be triaged for potential coronary CTA FFR pathway, but also as an ambulatory center to allow us to accommodate this large outpatient volume of coronary CTA. I've learned a lot from other institutions along the way who have much larger programs in terms of how to scale up and improve efficiency, getting a nurse navigator to help with triaging some of the more complex cases that come our way, including obese patients and arrhythmias. We're working on an in-house 3D lab that serves the entire health system, working on collaboration with pharmacy for beta blocker samples to be distributed in primary care physician offices as well as cardiologist offices. And then we're working on establishing new technologies at our institution that ultimately with the goal of enhancing and improving patient care. And education is the last thing that I want to talk about. This is something that's very near and dear to my heart. I am actually the fellowship program director, general cardiology fellowship program director at my institution. And one of the things that is very important to me is educating our cardiology fellows and trainees about the pros and cons sort of the various sort of imaging modalities. We'll talk a little bit about fellowship in a second, but the other sort of aspects of education are physician outreach as well as kind of reaching out to technologists. And in the outreach setting, it's working with our emergency department physicians and hospitalists, general cardiologists, and on the stable side, primary care physicians and family practice physicians, and really educating them to understand that this is a tool that's within their armamentarium that they can utilize, and helping them to understand the meaning of those results, and maybe taking sort of a step towards initial management and knowing which patients require downstream cardiology follow-up. I wanted to circle back to our ED algorithm and just show this up here, is that now that we have actually CT scanners capable of doing cardiac CTs at all of our hospitals, we are reinstating sort of an algorithm that we've incorporated that includes both heart score as well as high sensitivity troponin. I'm happy to share this with any of you who are working on developing an ED program, but we hope that this is going to be a successful effort. Education of technologists cannot be understated. I think once you have sort of a good technologist that can do cardiac CT, you want to retain them, and we do everything from an educational standpoint, and we want them to maintain sort of the certificates of competency that SCCT puts together for them. Education, we just put together this article, editorial in JCCT recently. A couple of my fellows and me wrote this, and really the focus is on the fact that the majority of cardiology trainees going into practice or going into academic institutions are trained to read nuclear medicine stress tests, but don't achieve COCAT's level 2 training in cardiac CT. And I think this is a dynamic that needs to change, and that's something that we've certainly started in our own cardiology fellowship program to allow all of our general cardiology fellows to achieve level 2 COCATs. And I think the same thing on the radiology side. We don't have a radiology residency program, but when we do have rotating radiology fellows, we certainly seek the opportunity to help engage them in learning and training. So just a quick recap in terms of where we've come from 2016 to the present. It's a whole orchestra of people that make this work, and we're prepared for what the future has to hold. Thank you.
Thank you. Thank you so much. Excellent talk. Now we're going to pivot. We've seen the guidelines have really leaned into a CT first strategy, class 1 level of evidence A. CT is going to be the first line test for so many patients, but now not only will CT be used to diagnose coronary disease, but as we'll hear from Dr. Collet, this innovative approach to really understand how to integrate CT in the Cath-lab, plan coronary intervention, and help optimize clinical outcomes. I think this is really a tremendous opportunity to hear from a thought leader in this field. Please, Carlos. There's your talk. Do I know how to find it?
No, but probably this one. Yeah. Thank you very much, Jonathon, and thank you for the opportunity actually to be here and explain you a bit more from the interventional perspective. How are we using today CT and in particular FFR-CT, not only to improve the effectiveness and the efficiency in the Cath-lab, but we think this will translate, of course, in improvement in the outcomes of the patients that we're treating following this pathway. The most important disclosure is in the previous slide. As I said, I'm an interventional cardiology, the other ones are here. But we see CT helping us in 3 ways. This is I like to call these 3 pillars. The first one is actually helping us in the diagnostic phase and in planning the procedure. I usually speak with Jonathon, and I kid with the fact that sometimes I'm impressed by the fact that we are the only people doing intervention that don't actually plan anything before the invasive procedure. And then we go to a diagnostic angio, we do 3, 4, 5 shots, and then we have around 10 to 20 seconds to decide what to do with the coronary artery. That, for me, is unbelievable when you see the other surgical colleagues, the way they plan their procedure. So that's the first point. We're going to go in depth in the first box. The second box is about how is the Cath-lab prepared. Every procedure in the Cath-lab is different, requires different material. Not everything is next to you. So this is very, very important, and CT actually help us have everything at hand. And the third part we will not cover today, but is the fact that we can integrate the CT in the lab to help us with a lot of things, including measurements and visualizing the disease. If we dissect this first flow chart into these 3 boxes and we try to understand a little bit more, we're going to focus on the first one, which is about lesion significance, but beyond the lesion significance that we are now aware of the cutoff of FFR-CT 0.8, there is something more that the FFR-CT gives you. And this, you're of course familiar with this. I heard yesterday that when you see the red, you go for the red, and I heard also someone saying about the rainbow, that the rainbow is more the diffuse disease. These are all new terms for me, but what I like to see here is that you can actually have a map of the pressure inside the coronary artery, and this is actually very, very important. Why? When you look inside the vessel, the way that the pressure is lost is different, and this actually divides coronary artery disease in 2 entities, and this is extremely important from the therapeutical perspective. In this case, you see here, when you click in this colorful model, actually you can get the pressure at any location of the tree, and if you take all these numbers and you put in a plot, you get what we call the pullback curve. In this case, you see a big step in that blue line over there. I'll try to take my mouse, if it works, here. And you clearly see that the pressure is being lost in a focal segment. Why is this important? Because stents are a focal therapy. They don't work in diffuse disease. They work pretty well in focal disease. So we have worked in the last few years validating this approach, and we have to acknowledge that all these pressure measurements that are done that derived from computational fluid dynamics really resembles the one that we measure invasively with invasive pullbacks. Even more, we can classify the disease, and one more time, beyond the significance, beyond the 0.8, less or more, in endotypes of diffuseness and focality. In this slide, you see on your far left, diffuse disease, where you cannot find a segment to actually be treated with a stent. And in the right side of the slide, you see a focal disease that's easily treated with a short stent. Let's take a small trip to the interventional world when we have realized that actually putting a pressure wire in the vessel, measuring FFR in the distal part of the vessel, and now pulling back the wire give us a second dimension of the disease. So it's not informing us only about ischemia and non-ischemia. Now the question is a different one. The question is, how can we help this patient? And we have 2 patients on the screen, both are number 2, but you see the yellow case is a patient, when we do the pullback, this is the invasive FFR pullback, is completely diffuse. There is no target for PCI, but the FFR is 76. So if you only measure the distal FFR and you don't do this maneuver, you may end up treating anatomical disease that actually has no functional repercussion in terms of focality. When you look at the case on the right side, you see here an FFR pullback with a big step. And these are the cases that respond pretty well to PCI. Now, can FFRCT provide us this? Yes. This is one of the cases that we are including in one of the recent trials. This is a right coronary artery. You see that anatomically, the disease in the angiography appears to be diffuse. But when you look at this with invasive pullbacks, and you see the pullback here again, this is invasive FFR pullback, it's pretty focal. And to do this, of course, we need to put a pressure wire down the vessel. We need to pull back the wire during continuous adenosine infusion. This takes about 3-4 minutes, and we had that already before the patient actually came inside the Cath-lab. And this is focal disease. I show you a picture of diffuse disease, which I love this case because when you look at the angiography, you see very clearly a lesion in the mid-LAD, and every interventional cardiology that measures an FFR positive in this vessel will go directly to treat this lesion. But look at the pullback. There is no pressure drop. This is not a case for PCI. On the right side, you see again the same information that we had even before we step in the Cath-lab. So that's the first box. Let's go now to the middle of the flow chart when you have the Cath-lab preparation. And I'm going to introduce this point with a case. And this is a patient actually coming in with stable angina. We started investigating this patient with CTA, and look what we found. A severe left main lesion, distal left main. I'm going to make a zoom here on the left main for you to see that it's a very, very severe lesion, subcritical stenosis. What is important about doing this approach is that this is not a surprise. When you shoot this in the cath lab and you find this type of disease, it's kind of everybody gets nervous, nobody knows what to do, someone wants to call the surgeon. Now this is completely under control. We knew exactly what we were going to find. We started with a guiding catheter, 7 French. The patient has been consented already to undergo PCI. We had the heart team discussion with the surgeons using the CT, and this patient come to the cath lab only to be treated. One more element concerning planning of the intervention, and this is related to the fact that CT can help us selecting the angulation that we're going to use to work in the cath lab. And you see here that you can actually move in this 3D geometry. You can actually appreciate the angulation that you have. But let me tell you something that in many of the cath labs, at least in mine, there are fixed angulations. So you go from 1, 2, 3, 4, RAO, cranial, LAO, and caudal, and you finish with a spider, and this is what you get. This is my standard RAO projection in my lab. And if I measure the lesion in this projection, this is QCA-based measurement, is 35.8. But if I say, no, the CT told me that we have to do an RAO 41, we never do RAO 41, but in this case, you see that the lesion is actually not 35, but 46 millimeters. And this, of course, changed the selection of the stem length. This is exactly the same length derived from the CT. So we are fully aware that of the potential of the tool. Now we are busy generating the evidence that is required to support all this approach. We have designed a randomized clinical trial called P4. The trial is already ongoing. We're going to include about 1,000 patients, and we're going to randomize them in 2 arms. One arm is called CT-guided PCI, which is based on planning the procedure, understanding the disease, before you go in the cath lab, and of course we're going to use the FFR-CT and the FFR-CT planner. And the control arm is what is, in our opinion, the best way to do PCI today, which is imaging, in this case, IVUS-guided PCI. This is a non-inferiority trial with MACE as an endpoint at 1 year. Thank you very much for your attention.
What a tremendous talk. Always remind me never to put myself on an agenda after Dr. Collet. Really an exceptional talk, and what's most humbling is he could have given that probably in 4 languages, literally. But I will do my best to follow him in the only language I can present in, which is English, I hope. But, you know, really, Carlos, that vision that you share that we've sort of embraced as it relates to structural heart disease is so exciting to all of us, I think. I know Dr. Shaw and I were commenting about, you know, really taking that information that we're going to be acquiring routinely and really optimizing procedural outcomes. It's really very exciting. So I'm going to pivot a little bit to understanding what's next in advanced analytics. I have some disclosures. Most relate to CT core lab work that I do, for which I take no compensation. I do give advice to HeartFlow. So what we're not going to be talking about is the core HeartFlow product, which is that of FFRCT. As mentioned, that's been extensively validated over the last 12 years. It's a mature technology with unparalleled accuracy compared to invasive FFR. The only tool that actually quantifies pressure that allows you a kappa agreement with invasive FFR of 0.82, not a probabilistic measure that there may be abnormal physiology, but rather quantifies physiology and co-localizes that physiology to an anatomical lesion, allowing people like Dr. Collet to plan intervention. We know it enriches cath-lab referral over and above CTA alone, as we saw recently in the discharge trial, 58% revascularization rate if you go to the cath-lab after CT. In the advanced registry, it was 75 to 82% following FFR-CT. And we know CT, FFR-CT are both now well positioned within the guidelines. What we also know is there'll be randomized trial data, as highlighted by Professor Shaw. This is led by Professor Douglas. Hopefully will be presented later this year at AHA. A very large randomized trial, evidence first, really driving forward this pathway and understanding how to best use it for the patients we serve. But what I'm going to focus on is about plaque. And you're going to hear a lot about atherosclerosis at this meeting. And I think we could all probably answer this question to some extent, why we care about plaque. It is, of course, fundamentally the process that drives incident myocardial infarction and drives abnormal physiology and drives angina. Professor Shaw led a very nice position paper from the SCCT, published it back in 2020. We know that just with visual assessment, we can look for stenosis, we can characterize the morphology of plaque, and we can look at the number of segments of plaque. And in fact, that number of segments of plaque is now very much embedded in Dr. Curry's CADRADS 2.0 document. The more plaque, the greater the risk. And of course, we've known this not just in 2022, we've known this for many, many years, very similar to the data that we've seen from the CAS registry. What we've seen consistently from CT registries is that the more disease you have, the greater the risk. And that holds true even for crude measures, such as calcium score or the number of segments of plaque. Beyond that, we've seen a really deluge of information that's come to us over the years, looking at visual inspection of plaque, looking at the morphology of plaque, and perhaps these features are incremental to the totality or the total burden of plaque. Features such as positive remodeling and low-density plaque, first taught to us by Sadako Moriyama and Professor Narula. And then subsequently, we and others published from the ICONIC registry that these very plaque features shown previously on IVUS may connote increased risk. So we all know we care about plaque. And we're going to hear a lot over the coming years about quantification of plaque beyond visual estimation, beyond calcium scoring. But I would put forward to you that what we need to do as we adopt such technologies is we need to make sure that they're supported by clear and confident evidence. I had experience, as did Professor Shaw, to be involved with an analysis that was presented last year at AHA, a quantitative analysis where the atherosclerosis was quantified within the ischemia trial. And yet you could see that the results were quite spurious and quite confusing. That total plaque was predictive, but yet non-calcified proximal plaque was protective. Non-calcified proximal plaque was protective. Wow, I didn't know that. I don't believe that. But it speaks to the fact that this is tough business. This is tough business and requires that the data and the tools be adjudicated thoroughly and thoughtfully. So I'll talk to you about a tool that is not yet ready for, not yet FDA approved, but a tool that is progressively being validated and one for which I hold a great deal of hope. And that is a HeartFlow AI-enabled CCTA plaque tool. So what do we need from a plaque tool? What should we be asking all vendors to deliver to us? The first thing it must be reproducible, right? As I was taught many, many years ago, if you don't have a reproducible tool, you can never be accurate. These are data put together by my colleague George Seamus from Lausanne, looking at this AI-based plaque tool and comparing it to manual segmentation using an off-the-shelf software in our CT core lab. And you can see that the plaque tool provided, AI-enabled, is not surprisingly, but importantly proven and shown to be much more reproducible than level 3 and level 2 CCTA readers. Beyond that, we need a plaque tool to be validated against the gold standard. You may hear some people suggest that this is unnecessary. I cannot possibly understand that logic, and I know Professor Shaw totally agrees, and so does people such as Professor Fuster. It really needs to be validated. At this very meeting, excellent data put together by Professor Safian from Beaumont and being presented at this meeting from the Miami study comparing IVUS to this AI-based plaque quantification tool from CTA in a blinded fashion with the global expert core lab CRF providing the adjudication of the data. And what you could see here is that, granted in a small study of 27 patients, really excellent agreement and excellent accuracy between the CT-based plaque quantification tool and IVUS core lab adjudication by CRF. So reproducible and accurate. Now, obviously, small study, we need more accuracy data, and I'll speak to that in a moment. We also need to understand how to integrate these plaque quantification tools into the cohort and into the populations we serve. We know from CADRADS 2 we have a P1, P2, P3, and P4 based on the number of segments. But what do we do with a quantitative tool? And to that end, Dr. Seamus actually presented earlier today, 11,000 patients referred for clinically indicated cardiac CT, clinically indicated cardiac CT, extracted quantitative plaque volume, providing us sex and age-based nomographic data. very important clinical utility information such that we can begin to understand how to integrate these quantitative tools into our practice. And finally, I would close with the concept that plaque is but one needed element, that it's a complementary role of plaque in physiology, as we heard from Dr. Collet. We saw from Professor Kuhn, now published a couple of years ago, the interplay between plaque and physiology, that patients with abnormal plaque morphology had an increased risk, but that risk was heightened further by those patients that had abnormal plaque forces, defined by translesional pressure loss, or delta FFR-CT. This is not ascertainable solely by the plaque, but it is a complementary role, and this has been shown not only in the CT world, but also in the invasive world, that patients with adverse IVUS plaque with translesional pressure loss are at higher risk than those without translesional pressure loss. And then ultimately, as we want to integrate these tools, I think we need a framework for image analysis and transfer. We use the FFR-CT technology and have done so for some time. I think the ability to routinely ingest and return data in a feasible and a robust and a reproducible fashion, I think is fundamental for us to integrate these plaque tools in our practice. Now, why I'm most excited and why I've always been a supporter of and an investigator with and now give advice to HeartFlow is because they really have always led with investments in science and in evidence. And here are just two examples of such evidence in science. Emerald-2 will be an exceptionally important study that will help advance our understanding of the interplay between mechanical forces and plaque and risk in a very large core lab adjudicated study, and a very large quantitative plaque analysis compared to IVUS. Compared to IVUS as a gold standard, led by Professor Narula and Dr. Stuckey, two very important studies. And obviously, I think what we all as a field need to remind ourselves that even with all of this data, we will still need as a field to continue to understand what sort of trials will need to be done to show that quantitative plaque is in fact incremental than segment-based scoring or than calcium scoring. And I think those are the questions that we as a field need to continue to ruminate about and seek support to actually carry out such evidence and bring it forward to our field. Thank you again for the opportunity. I'll stop now.